Okay, come on in and please take a seat. Come on in, come on in, come on in. Let's take a seat. There's a few seats out here. Okay, welcome everybody to Hormone Harmony and the Vitality Revolution. Thank you everyone for being here today. We're going to go in depth into this topic today. We have two incredible guests, so you guys are going to leave with a lot of knowledge, okay? But before we get there, can you permit me a few words? This time right now is very special. A lot of you guys know the story. Some of you guys have been with us since we were working out in Athleta, in Lululemon, in Reebok, in Tory Burch. We did the tour of all of the stores, right? And you guys were there supporting us. Some of us were even there in the dusty basement. And you guys remember that time. So I'm just so grateful to see so many faces here. Some old friends who have come back to say hello, and just the camaraderie is awesome. And so we're doing this tonight. Yes, we're going to talk about hormone health and hormone vitality, but it's also a celebration. It's a celebration because of the clients who were here and the clients who have come back and where we're about to go. We started here in 2019, July 2019, with the grand plan of having our big launch on March 16th of 2020. Fantastic plan, we had it all laid out. That's the exact date that the gyms were told that we needed to close down. So I was sitting there with that guy, Celine, and we were like, we don't know whether we're going to survive. We don't know what's going to happen here. And that was 2020, 2021. You guys were there, 2022. And the first proper year that we had when there was no craziness was 2023. And we thought to ourselves, we might actually be able to run a business, right? This year's gone really well. And so I say that to say that we've spent a long time doing the things that we had to do. Things that we had to do to keep the lights on, the things that we had to do to pay the rent, the things that we had to do just to keep the business surviving. And so thanks to you guys. In fact, I know it's a little corny, but if you come to a Race Life class, you've done any personal training, you've come to one of our events, please just stand. Please, 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 please. Thank you. Thank you. Really, from the bottom of our hearts, thank you. Because, you know, you see small businesses working and you see us putting things together. And I know that sometimes you recognize where we're duct taping it together and just making it through. And I thank you for hanging with us during those times, right? But we're at a place now, we're not there yet, but we're at a place now where we've done a lot of what we had to do. And now we're going to start moving into some of the things we want to do. And want to do to serve you guys more, want to do to have, like this evening, having an incredible host, an incredible guest to get you guys more information. And look, you see the transformations, you see our clients here, but it's, there you go. But it's not just about that. It's about the journey. It's about the community that's built here. It's about, yes, this is outward transformation, but it's about what goes on inside. So yes, we're going to have more relationships with wellness doctors. People who sign up for us from now until January 31st, you'll get your free biological age test. We have a juice regimen coming. We have more wellness doctors coming, Pilates. It's going to be a full 360 integrated personal training system that we don't think we've seen anywhere else, right? So it's going to get very, very bougie. So I'm just telling you right now, because come January 31st, we're going to switch up, all right? Now, that being said, you guys who are here, we'll take care of you, obviously, right? But it's a good thing to be here right now. The other thing is, you know, please look at, you've all got like these invitations to wellness in the gift bags at the end. Please look at that, take advantage of that. And here's to the next 10, 15, 20 years and what we're going to build. So thank you so much. So now to this evening. We have client, friend, actor. You've seen her on The Boys, on Amazon. You've seen her in The Man in the High Castle, New Amsterdam, and the newest Amazon hit, Fallout. Frances Turner is our host today, so come on up, Frances. And I've already done an interview with our next guest. She has a wealth of knowledge. This is a career committed to women's health. She is a surgeon. She ran her own thriving practice for many, many years, and she stopped that. She's working with a much larger group, Atria Health, and there's always one. And they have a group of very high-level doctors who are, I'll let her explain, but put together a consortium. So they've got the best minds put together based around women's health. She's also working with Atria right now, who is part of that group. So you are in for a treat. Please today, like typically it's book signing or we have a certain kind of guest, but today you're going to get your questions answered. So please take advantage of today. So, Dr. Poyner, please come on up. Bougie event, that's right.
So, welcome everyone. I'm so excited this evening. We really want to create a space for. Hello? Okay, so this evening we want to create a space for open and engaging conversation where we will, you'll get practical advice, actionable advice. We want to break some of these preconceived notions around women's health, and we want to challenge the ideas that are out there and just really kind of become empowered about our bodies and how our bodies are changing. And we hope that you leave here this evening with a sense of empowerment and enlightenment and liberation, feeling liberated and with renewed sense of ease and hope in managing your health, your overall wellness, and your bodies. Women, we are living longer and longer. We're living longer than men, but with fewer years of active good health, right? So it's important now more than ever to really take control of prioritizing our wellness. So we want to do that. We want to talk about that tonight, and let's get started. I have some Oprah style notes. I have a lot of questions. Full disclosure, as Robert mentioned, he is my trainer, along with the wonderful trainers here at Grace Life for about 3 years now. I'm here 4 times a week. And Dr. Poyner, my gynecologist. And how I found her, she was also my mother's friend. And since she's retired, I miss her dearly. And she is also the doctor who got me started on my HRT journey, which has changed the quality of my life. So. All right, so let's talk all things hormone health and menopause. I'm not going to assume that everybody is coming to this conversation with the same level of kind of knowledge about our hormones and what happens to our bodies. So menopause 101. What is menopause? What are the stages of the menopause spectrum? What happens to our bodies?
So menopause is defined as the final menstrual period. Postmenopause is 12 months after the final menstrual period. I think that was on. Sorry. So menopause is the final menstrual period, and postmenopause is 12 months after the final menstrual period. But we don't know when that is, right? So perimenopause is really that time period before the final menstrual period and after the final menstrual period. So, but the hormonal fluctuations that occur with the final menstrual period start between the ages of 35 and 45. So this is a real active area of interest, and it's my area of interest because we want to pick up things before they kind of go off the rails. So menopause, final menstrual period, postmenopause, 12 months after the final menstrual period.
Can you talk to us about more about perimenopause?
So perimenopause is a really kind of misunderstood time, but it's kind of when your hormones are going off the rails, actually. And you can take it, I liken it to just a shattered glass. You can take a glass on the floor and just throw it on the floor, and it shatters into all these different estrogen levels, progesterone levels. Some months you have high estrogen levels, some months you have low estrogen levels. So it's when your hormones are really shifting. And it's the ovaries are actually they're aging. They're not producing estrogen the same way. So those are the years leading up until that final menstrual period.
So that's what's happening to our bodies and our hormones during the perimenopause phase. What's happening to our bodies and our hormones during the menopause phase?
So in menopause, it's when about anywhere between 2 and 3 years after that final menstrual period, right? Still a year after the final menstrual period, maybe even 2 years, you're going to have some fluctuating levels of estrogen that you might not perceive. But about 3 years after the final menstrual period are really into those postmenopausal time, then our hormones become very flat. Actually, estrogen is just low. It doesn't go up or down. It's just low, and progesterone is just low. And testosterone, which we don't talk about so much in women's health, but we need to, is also low.
What are the symptoms of what are the
Some of the earliest symptoms of perimenopause are the really subtle ones. Like the first one that I always hear about, that I talk about a lot, which is really relevant to these here at a gym training facility, is shape-shifting, right? So when our estrogen levels start to go up and down, our waist starts to expand. And our waist is expanding because we're depositing fat in the abdomen. It's called visceral fat. So that's one of the first things that happens in perimenopause. Other more subtle symptoms may be brain fog. You may forget those names. You may forget memory. Yeah. And right. Why? Just as long as your keys aren't in the refrigerator, you're probably okay. But brain fog is a big one. Lack of concentration. People who have ADD may feel a little bit more ADD-ish, right? And then libido and vaginal dryness. So libido is one of the first things that also kind of tends to trail down in perimenopause. Anxiety, mood issues can start. And these are times too when you go to your doctor many times they go, oh, your hormones are just fine. Everything looks good. Because we don't see the changes yet in the blood. We can only go by the narrative or what you guys are telling us, basically. So the libido may be off, and then vaginal dryness in the second half of your cycle. We may see that as a painful intercourse. Those are kind of early, subtle changes of perimenopause.
And there are symptoms like hair loss.
Hair loss can begin. Hair loss tends to occur, I think, a little bit later, actually, but when the estrogen levels are really starting to tank, because in perimenopause, your estrogen levels are going down, but they're going up and down as they're going down. So your scalp you still have some collagen in your skin.
And things like frozen shoulder.
Yeah.
All kinds of symptoms that are talked about.
Yeah.
A lot. Frozen shoulder.
Sure. So there are 97 symptoms of menopause. 97, and there's probably 127, right? So there's 97 symptoms of menopause. The FDA, in terms of hormonal prescribing, recognizes 2, basically, maybe 3 if you count bones, right? Like hot flashes and vaginal dryness. But definitely, so there's estrogen receptors all throughout the body. So almost all tissues have estrogen receptors that they express. So frozen shoulder and joint issues are estrogens going down. It's affecting our bones and our muscles, bones, and joints. Bones we are well recognized, but joint issues also, and inflammation. We get inflammation also.
So I wanted to talk about specifically the effects of menopause and the decline of estrogen on brain health and cardiovascular health and your joints and your bones.
So brain health, I'll start with brain health. I could talk for hours about brain health, but this is an area of emerging research. And we know that as estrogen levels start to go down, and one of the areas that I'm really looking at is what does brain fog correlate? Can we look at brain biomarkers? What does that mean physiologically for us? But as estrogen levels start to go down, we see the changes which are consistent with Alzheimer's, actually. Plaques and tangles start in our brain, perfusion to the brain changes, metabolism in the brain changes. We don't use our nutrients the same way in the brain, actually. And we see changes in the size of the brain. Areas of the brain actually that are associated with memory and learning get smaller. And in perimenopause, actually, way before menopause, we also see changes in estrogen receptors in the brain. So as we go through menopause and perimenopause and menopause, estrogen receptors in the brain go up. And it's like the brain, Dr. Mosconi, who's a big researcher in this area, states so eloquently, the brain is hungry for estrogen. And so now we know, and we have some data that shows if you start hormone replacement therapy early on in that menopausal transition, that we can help protect from dementia, because dementia affects women 2 times more than men. And 2/3 of the individuals with dementia are women. So we have a very skewed risk of dementia when compared to men. Cardiovascular health, those changes probably start in the perimenopausal times, actually. So lower levels of estrogen actually lead to more inflammation and also an adverse change in your lipids. So cholesterol goes up, the bad cholesterol goes up, the lipids go into the blood, and then you can get coronary artery disease.
blood pressure goes up at the time of perimenopause and menopause also. So if you look at the guidelines and recommendations, like, oh, get your blood pressure checked every 2 years. Well, by then you have cardiac disease probably getting really established. That and then bone health, of course, in terms of as estrogen levels decline about 3 years before the final menstrual period. So in the perimenopausal time, you can tell I focus on perimenopause in my interest. But 3 years before the menopausal transition, bone health, we start to lose our bone health, and our bones become thinner and more brittle, actually.
So let's jump right on into hormone replacement therapy.
Yeah, let's get to the good things. Let's talk about the good news.
Because hormone
That's the bad
replacement
news.
therapy has re-entered the chat
Yeah.
in a more evolved way than it has before. And I know when I reached the stage earlier this year, you had been talking to me about it for months, but I was operating from a place of the misconceptions that are out there that are just in the ether, just what you hear. So talk to us about hormone replacement therapy and give us a little overview of those misconceptions and how it's different now.
So we'll start with a little bit of history, actually. So I always say it's really great to have an old doctor because an old doctor has really seen it all. So when I first started in gynecologic oncology, like I was taking out ovaries, and I would take out ovaries for whatever indication, largely related to cancer. But at the same sitting, I would hand you a prescription for estrogen and be here. This will protect your heart. So everybody went on estrogen because we knew at the time that estrogen actually protected you against cardiac disease, which is the leading cause of death in women. And then a very large randomized trial, which is the gold standard of trials, was published in 2002, which showed that the risk of breast cancer with 2 drugs that we don't use, by the way, anymore for hormone support, increase your risk of breast cancer by 25%. So that if you had a 14% chance of developing breast cancer, this went up to 17%. And these headlines were splashed across the New York Times, and everybody said, you have to stop estrogen, it causes breast cancer. And then we looked at a subset analysis of the data. So all of this was prematurely published, prematurely splashed across the newspapers. But when we did a subset analysis, we saw that although these drugs that we don't use anymore had a slightly elevated risk of breast cancer, they really did protect you against cardiac disease and decrease your risk of death by 30 or 40%. And cardiac disease is a leading killer in women, not breast cancer. So, but our newer medications about the same time, this is very long-winded, but then I'll be done with this because I'll get to the punchline. Our newer medications are better. About the same time that we were looking at these 2 medications that we no longer use, the French were looking at more advanced, more natural hormones. And the French published a study about the time of the Women's Health Initiative study, but nobody paid attention to it, right? Because it wasn't our gold standard study, it was an observational study. And what the French showed is that we have safer medications. Estrogen transdermal, so that applied against the skin, either with a patch or a gel, and an oral natural progesterone is much safer. Doesn't increase your risk of stroke, DVT, or pulmonary embolism, and doesn't increase your risk of breast cancer. So true to form, in our country, sometimes in the medical industry, with women's health, we threw out the issue. We threw out menopause, and we didn't throw out the drugs. So if you have bad drugs and cardiac disease or high blood pressure, you throw out the drugs. But with women's health, we just said, oh, we can't do anything about that. So, but despite this, right, these people really hold on to, and still some very good doctors will hold on to, oh no, it causes breast cancer. You can't take those hormones. But our newer preparations are super safe. And for most women, the vast majority of women before the age of 60 or within 10 years of menopause, you're going to get great protection with hormone support.
Some women may have fears about estrogen that may be outdated. What would you say to them?
I would say that the medical industry establishment has done women a big disservice. And what I typically do is I review the data in a high-level fashion in terms of our newer drugs are safer, right? And for the vast majority of women, does not increase our newer drugs do not increase your risk of breast cancer to the same extent that our old drugs do, maybe not at all. It does not increase your risk of stroke or other complications, does not increase your risk of cardiac disease. It started within 10 years. So I have to say it's more about talking about how we did women a disservice and how we still continue to. This is why I'm in a new position where we're talking about how do we get technology to help women get better care.
Testosterone is another hormone that we should be replacing. Totally. But some women hear testosterone and have all kinds of ideas about about what that means. Am I going to get a mustache? Am I going to be like
That's the right way.
Can you help dispel some of those
Sure.
notions?
So molecule per molecule, right, in our blood, women have more testosterone than they have estrogen, right? But again, true to lack of curiosity and lack of research, nobody looked at it. It's like testosterone is for men. Well, actually, women have a lot of testosterone, and it's just that we talk about estrogen. But as we age, testosterone actually goes down, and the Brits have more they have more experience maybe, or more interest in testosterone, as well as the Australians do actually. So a lot of the data relating to safety and utility of testosterone comes out of European and Australian countries, right? So but probably testosterone does help with cognitive function, helps with memory, helps with bone, helps with body mass. Building lean body mass is more difficult when we're older, and testosterone definitely helps with that. But maybe go beyond that and have some cardiac protection also. There's a study looking at testosterone use in women, and is the contractility of the heart, or the pumping of the heart, better in women. So definitely there's a lot of interest in testosterone.
Great, that's awesome. So a woman says, okay, bioidentical HRT is something I want to try. What does that look like? Is there a blood test to check her levels? Are they checked regularly going forward? You say, I always tell people when I talk to them about HRT, I think my doctor says HRT is an art, not a science. So how do you know when it's working or not working?
So this is where we have to really listen as physicians and healthcare providers. Like, what are your symptoms? What are you going through, right? And then you have to look at those symptoms and get an outcome. But we also should be checking levels, because all of the studies that are done that show us this kind of brain health protection and cardiac protection are done with kind of medium levels of dosing. So what we do is we start with a narrative. What are you experiencing? And then we start with usually a patch or a transdermal estrogen and an oral progesterone. And then we just assess, and we do high-level, high-touch communication, and that may be 2 weeks after you start, because you can get some bloating, some pelvic pain. 2 weeks, a month, 2 months, check some levels and see how you're doing. And typically what a lot of people will do is we dose to your symptoms, and then we check levels, because I also want to make sure you're getting those protective levels actually for your brain and your cardiac protection, your metabolic protection, and your mental health protection.
A question I have, this is when my hormones started fluctuating, it took me some time to figure out, is this just life? Or like, am I just like, I'm in a crazy career, so maybe that's why I'm feeling a little down right now, or, whatever it is. How do you, maybe that's why I'm not sleeping or whatever. How do you really, how does a woman kind of parse that out? What's life and what's my hormone?
So my answer to that question is usually multifactorial, right? Usually it's not A or B, right? It's usually many things are impacting the physiology of your body, because remember, what is going on the outside of us, we bring into us actually through this axis called the HPA axis, right? So if we have outside life stressors, they may be jobs, they may be family, and kind of those perimenopausal years, menopausal years, where our kids are like, if we have them, they're leaving the house. There's a lot of changes. We may be having relationship issues, job issues.
Parents getting old.
Yeah, parents getting old. Yeah. It's kind of a perfect storm. So it's like kind of this witch's brew of all this stuff is happening. And so I always kind of say, like, you paint your life on a canvas, and the canvas has different colors. And you may shift to a brighter color for you, actually, if your hormones are shifted. Doesn't mean that when you do hormone support, it's going to be the answer to all of your problems, but it's going to help you deal with some issues maybe that are going on in your life a little bit better. So you have to listen as providers and physicians. We have to listen, and we have to make sure we get an outcome.
How should a woman advocate for herself with her doctor if she wants to explore HRT?
You got to get to the right doctor. Yeah. They're still left in this world, and I still don't get it. And I'm working hard, and there's a group of us working hard to kind of change that. And this is where social media has really helped, actually, because I actually have a slide that I show the history of HRT. And then, 2020, when kind of telehealth started up with COVID, like there's some stuff that came out of COVID that was actually good in terms of telehealth and talking to maybe people who were a little bit more experienced or had curious about a topic. So it's like, so you have to get the right information and you have to make sure that you get to the right provider. And still to this day, there are providers like, I'm not prescribing that. I don't know anything about that. And kind of my recommendation to them is you better learn about it because every woman goes through it. And so you're not taking care of your patients if you don't know about this and not educating yourself. So, but until we get everybody, all the providers educated, there's definitely great books out there. There's great advocates out there. There are great Alloy, Evernow, Electra Health. I'm actually involved in Electra. Those are online communities basically that can help you. So you can use technology, and this is my area of interest, of getting better care.
Are there women who should not be on HRT?
Definitely. So women who've had a stroke or an MI within the past 12 months shouldn't be on HRT. If you had a stroke or an MI in the past, you can talk about low-dose transdermal HRT. Estrogen-dependent malignancies, breast cancer is the big one. If you've had breast cancer, HRT is contraindicated. If you're having life-altering symptoms and you have an early-stage breast cancer, some of us will actually review with you using HRT and such. So there's very few absolute contraindications, actually.
Okay. And you're seeing a shift in attitude amongst women patients around HRT and the willingness to discuss menopause in a real way?
Totally. I love it. Before I exited my practice and went to Atria, people would come to me with their Instagram post, and I saw this post. I'm like, great, let's talk about this post, right? And so I think that women are definitely, coming in more and more and more and advocating for themselves, actually. But like I said, we have to get the healthcare providers to catch up because we haven't caught up yet.
Right. Thank you. So now I want to talk about lifestyle intervention because, HRT is one facet of it and you may decide to go that route. You may decide not to. We know what's happening to our bodies, our hormones, we know about hormone replacement therapy. What should we be incorporating into our lives as we navigate menopause and promote overall health? So Robert, I want to start with you and the importance of fitness and exercise. What would you say there?
Well, first of all, I think she's giving some incredible information, right? Look, one of the main things that can help, and I'm sure Dr. Poyner will agree, is strength training, right? And there's so many, you look around, and I'm sure many of you have heard, oh, you don't want to lift too many weights because you're going to get bulky, you're going to look big, you're going to look manly, right? And the truth of the matter is, as you go through menopause, as you advance in age, the strength training is going to build your lean muscle mass, which is going to increase your metabolism, which is going to keep you strong, but also if you're thinking about aesthetics, it's going to help with your aesthetics. It's also going to improve your bone health. So one of the things Dr. Poyner talks about is as we get older, the thing that can cause more diseases is frailty, right? So feeling frail, not having strength, not being able to lift weights, that's going to translate down the road to not being able to open the jaw, to when you fall on the floor, not being able to get up on the floor, right? And so you want to be able to have a proper strength training program that, the women in the studio lift weights, they lift big weights, right? It's, cardio, obviously, there's roles for specific types of cardio, but I think that is the main thing, right? We can go into nutrition, we can go into when to do certain types of cardio, because depending on where you are in your cycle, if you're doing too much interval training, that could spike your cortisol, and so you might not want to do it at that point. But again, strength training is number one.
And you mentioned nutrition. What could we be doing? What should we be doing as we go through these stages of life to best support our bodies?
Feed your muscles with protein.
Okay.
So you've got to have enough protein in your diet to feed those muscles that they can bring.
Totally. And it's sometimes hard to get in. Like I usually recommend 40% of your macros should come from protein, and you have to focus on it.
Yeah.
Totally.
Non-HRT treatments. and supplementation. Are there any other treatments? I remember when before I just decided on HRT, you had prescribed me like a maca supplement and things like that. And I'm seeing commercials for it. Maybe it's just like, the algorithm is just giving me all kinds of things related to menopause. But I'm seeing like commercials and on online ads for a non-hormone prescription medicine that's supposed to help with hot flashes and things like that. But do those things give you kind of the protection?
So they don't.
We're looking for
So maca can increase estrogen levels, progesterone levels, help with hormone balancing, and there's some data. I usually talk about things that have peer-reviewed data, right? Black cohosh, red clover may help with hot flashes and some issues. Ashwagandha can definitely help with kind of stress management issues that can be inflammatory, right? Because stress is inflammatory and lower estrogen levels are inflammatory. These are all, many of them are what we call phytoestrogens, so they're very weak estrogens. So they're plant-based estrogens. So they're hitting that receptor a little bit, but not a lot, right? So we don't have that long-term data. They're not going to probably give us the same cardiac benefits, the same brain health benefits, but you're going to get maybe some symptomatic relief with some of these marginally, but not to the same extent that you would with hormone support. But some people can't use hormone support. So these in combination with nutrition, there's some new data coming out that microbiome work is actually really, really, really important. The Zoe group actually is a UK-based group that really looks at microbiome. And what they're correlating is better microbiome or eating good fiber, having good healthy nutrition, no sugar, cutting back on processed foods, actually decreases menopausal symptoms. So we're beginning to look at more natural therapies and decreasing symptomatology. It'll take years before we know that if you get the same brain health benefits and the same benefits in terms of hormone support with cardiac health, but you're going to get benefits from a healthy lifestyle, period. So you might not get incrementally the same amount, but I always tell people you can't just take estrogen and not have a healthy diet or nutrition or lifestyle. Right? It all works together. Right. It's all complementary.
Yeah, there's so much amazing information that you're giving all of us. So thank you so much. Robert, I am always impressed. I'm here 4 days a week. I am always impressed by the studio. I'm always amazed by what you've been able to create here. It truly feels like a safe space. But everyone in here is working, like getting it in. But we're having fun, we're dancing, we're laughing, and we're lifting very heavy weights. Why is this creating this space, this mind, body, soul connection? Why is it so important to you?
Oh, that's a good question. It's important to me. I've got to go back to my family, right? Because my grandmother, who some of you have heard of, she was an entrepreneur. She came from Ghana and moved to England and built this great fashion company. My mother worked from home so she can send us to great schools, right? And I always used to look at them, and they were always working. They didn't stop to have time for themselves. And one of my best memories is when my mom, she was a seamstress, she got off her machine, and she actually spent time with me, right? And then I have my wife who's an entrepreneur. My daughters both want to be entrepreneurs. They come to me with ideas about what they want to do and how they're going to make all this money, and it's awesome. But I think for me, wanting to see those women strong, healthy, and the kick I get of seeing them fly doing what they do is part of just how I've grown up. So I think naturally it's just come about that way. But more than that, the thing that I get a kick out of is, there was one particular client who, and this is about aesthetics, but it's bigger than that, who said, I was walking past a store and I saw a white bikini, and I said I would never be able to do that again, right? And then she was like, oh, hold on a second. The way she's training now, she will be able to do that. And so it's a small thing, but it's about empowering the people who are here to know that there is another place you can get to. It's not over. There is more that you can do with your body. A lot of our clients say they're in the best shape of their lives, and actually they are in the best shape of their lives, and they're more, have more endurance, all of that stuff. And so for me, it's about creating that community. And one of the things we talk about a lot is making sure people feel safe when they walk in. People feel seen, so that, we recognize who you are. You feel celebrated, right? And so that's what these pictures are,
Preach.
to make sure that everybody feels seen, safe, celebrated, and finally, so they will kill me if I don't say this, feel sorry. Have people sorry.
These pictures are stunning, amazing, amazing. The strength, the beauty, and they're not just run-of-the-mill before and after photos. They're real celebrations of these women who put in this real work, and their outsides are matching their insides.
Right.
Well-known photographers, styling, lighting, all of that. Why was it important to you, to approach you in that way, to approach these photos in this way?
I think it's important to always have a reminder of what you are able to achieve. And most of the people in these pictures have said, "Oh, I'm not doing that," when they first walk in the door, right? They're like, I don't want to be, no, we're not doing that picture, right? And then they do it, and it's about showing people a milestone of what you are able to achieve. Yes, there's the before and afters, and we've seen those, but I think it's more important to always have a reminder of how far you can go, and always, and that translates into other areas of their lives. So.
Wow. So, whoa, this, I feel so overwhelmed, because this is the kind of conversation I was looking to have at the start of the year, where I was just like, there's no information. And then all of a sudden, overnight, within a matter of months, it's like everybody's talking about menopause. I'm like, every time I turn on TV, Halle Berry will not stop talking about menopause. And I love that for all of us. And I think it's because, we're, as women, the most empowered than women have ever been in our voices, in our careers, in our social relationships, in our earning power, our spending power. And so we have a real voice, and I just love to see all this conversation, because I think we owe it to, we have a more empowered voice than our mothers had, their mothers had, generations of women before us. And I think we owe it to them and to ourselves to keep having these conversations and sharing information. Quick little story, when I finally decided, okay, I think I'm gonna start HRT, is when I just started falling asleep at 11 a.m. every day, just wanted to lay down. And I was like, this is not normal. This is not like, this is hormonal. So I said, okay, I think I'm ready to start. It was a Friday. I walked out of your office, and I said, I'll text you over the weekend. I said, I just want to read any more articles. And then I'll text you.
And I listened.
over the weekend. And she said, okay, just text me, and then I'll send the prescriptions in. I've had the same friend group since I was in the second grade, right? Second to fourth grade. One of them is here, and we've been friends since the fourth grade. Okay. One of them is also my cousin. That's her best friend. We some are married, some have children, some don't, some all of that. And I walked out of that appointment, and I sent a very simple text to our group chat. I said, I'm thinking about starting HRT. Are any of you on it? XO. When I tell you that led to a 5-hour text chat, we had never talked about this amongst ourselves. 2 were on it. Everybody was suffering in some sort of way. One who's a doctor was like, oh, I don't know if we should do that, but she was suffering. Now, all but one of us are on it, and our quality of life is so much better. And I was able to get the answer that I was searching for. I was like, I just want to talk to someone who's on HRT that maybe didn't start right away. I just want to know that it does make you feel better, that it does improve your quality of life. But I can't just walk up to random people and say, hey, are you in menopause? I'm not doing that, because I wouldn't want anybody to do that to me. So sending that text and hearing the replies just made me, it just made my mind up. And one of my friends, she said, I had no idea that she was suffering in this way. And she said, she was basically trying to treat all of the symptoms that she was having and not connecting them to her perimenopause. She was seeing the dermatologist and getting medications there. She was seeing the endocrinologist. Finally, she said her period just would not stop coming. So she sought out the leading specialist where she lived. And the doctor said to her, You were like all the other women who come to me after seeing the dermatologist, the endocrinologist, the psychiatrist. She said, you are in perimenopause. And she weaned her off all those medications. She put her on HRT. And I said, do you feel like your quality of life is better? Do you enjoy the back? She said, not only is it back, I never knew that I could feel this again. She said, I thought that this was just what life is supposed to be at this age. She said, I felt fine, but I didn't feel good. And I didn't know that I could feel good again. And she said, and this makes me emotional, she said, I'm so thankful to my doctor. So, that being said, let's take some questions. And thank you to my doctor. I'm sitting here. And to my trainer.
Thank you. So thank you to all of you. So I'm a client. I always say that I have the distinction of being the last person here on Friday, March 15th, and the first one to come back when he reopened, when it was safe. So, I'm 61 years old. I work out. I feel like I'm healthy. I'll occasionally have a hot flash. I've associated with when I get annoyed, if I drink more than I think I should or something, like I have a cocktail. How do you know that you need it? Like, I'm sitting here going, I think I'm fine. Like, if I work out, I get into shape. If I eat right, everything is healthy. And then two girlfriends just said at my birthday the other day, hey, I just started the patch. And I think because I'm 61, I remember those headlines. So in my head, without subconsciously, estrogen is bad. And so hearing you say this, I'm like, but how do I know? Like, is there some 20-question test that we can go, if I see these things, I should talk to my doctor?
So this is one thing. So this is something that is really interesting, because there are women who, 80% of women have vasomotor symptoms or hot flashes, right? So the majority of women will have some symptoms from menopause, but about 20% of women won't actually, and will feel great and say, I just feel fabulous, right? And the question really is, are you at the same cardiac risk if I feel fabulous, I feel great, or the same brain health risk, right? So there is some data that vasomotor symptoms or hot flashes are an independent risk factor for cardiac disease. So there's an elevated risk of cardiac disease. So giving somebody who's having hot flashes estrogen may be incrementally better for them than it would be for somebody who doesn't have symptoms. So the fact that you feel well, in our current prescribing practices is we don't usually prescribe unless you're not feeling well, right, or have some symptoms. Over the age of 60, so there's some brain health data that's also come out recently that if you miss this opportunity, this window of opportunity, it may be worse for your brain health to be on estrogen. So generally, if I have somebody in my practice who's over the age of 60, feels great, hasn't been on HRT, I don't start them on HRT unless there's some issue that's pressing, right? But I recommend all of the great lifestyle things, healthy nutrition, healthy exercise, stress management, sleep. But we also have to question too, when we're talking to our patients or our clients who are considering HRT, a little bit beyond hot flashes and vaginal dryness and bone health, right? We need to talk about, how is your cognitive health? How are you feeling? How's your stress? How's your anxiety? Depression. So, but generally, over the age of 60 or 10 years after menopause, we don't usually start, and I wouldn't worry about it too much because you're probably in that group of people that probably does well, actually. So, and there's some data now that's coming out too, like with vasomotor symptoms or hot flashes and brain health, that more vasomotor symptoms may actually equal more problems with dementia later in life. People are beginning to talk about that, and that data is starting to come out.
So that's the other concern too. So if there's a genetic component, like my mother has Alzheimer's, she's 91, so that's what's got my attention. I'm like, what can I do?
Right. So for dementia prevention, right? So it's exercise, right? Healthy nutrition, anti-inflammatory nutrition. Good stress management, good sleep, good sense of, I'm going through this because it's good sense of community, which this is great. I love community, and sense of purpose, making sure you got a reason to wake up in the morning. Those are all super protective of brain health. And these studies that look at brain health, right? Estrogen for women is never on that list, actually. But we do know when we look at estrogen that it does equal better brain health, but maybe for a subset of people. But so this is why I say perimenopause and menopause are an opportunity. You can choose to live and lead your life in a super healthy fashion and age with strength or not. right? And so that's all of the great lifestyle things also.
Thank you so much.
Any other questions?
Hello. So you touched a little. Where would we go? Like, who would we go see? Like, is it an OBGYN? Is it a neurologist? Is it an endocrinologist? Like,
So for prescribing or to have conversations about perimenopause and menopause, it's usually an OBGYN, right? Or somebody who's focusing on gynecologic endocrinology. An endocrinologist, even a GP or family practitioner should be trained in this because, again, everybody goes through it, right? It shouldn't be a super specialist, right? But right now, it's a gynecologist who's interested in an endocrinologist. And also, there's a list of, like I said, there's online resources, but there's also a list of providers in the Menopause Society. So there is something called the Menopause Society, which is a well-respected professional society. You can go online. There's a list of doctors. You know, you can ask for resources. So there are resources there to get you to the right doctors.
in the back.
Hi, I'm Cara and one of the Brace Fitness clients of the past. I guess I'm thinking not for me. So I guess once we get over 60, then it is what it is, right? But I think about the next gen. I always go back to and think about if I had known then what I know now. So what should we be telling our mentees, our nieces? I don't have kids, so that what should they do in their 40s? You know, what should they do? You know, more and more I'm getting smarter. I now know about nutrition and yeah, hey, Cara gave up gluten and lost 10 pounds, you know, and other things. And it's really about inflammation. There are those things. But, you know, again, as we're thinking about that next generation, what will we have them do that we didn't do?
I think to be proactive, actually. I think for our next generation of women, we can be more proactive. And this is why I'm actually very interested in these, what we call late reproductive years, before you start having menstrual irregularities. But we know like cardiac risk are starting, or we know that some of these other kind of physiologic or metabolic risks are starting, right? So I think to be proactive and just know that we have to be aware of wellness. You know, we were talking the other day, it's like these signs that we had in first grade really are right. You are what you eat. You know, there's a reason why we were put in gym class in grade school, basically. But to be more proactive and to listen to your body. And I also think it's really important, and I see this, to advocate for yourself, to listen to your body. If something's not right, don't get an answer. You know, make sure that if you feel like your memory's off a little bit or you may be perimenopausal, you know, be aware of that and get to the right people to help you with it. And don't take, oh no, it's just aging. Every woman goes through it. You know, we still hear this, which is really sad. But now with the power of more communities, so, you know, internet communities like this, you know, that knowledge will get out there. You tell one person, then you tell another person. It's like that old-fashioned Brett commercial. Then that becomes, I could tell, yeah, you know. And then so getting that out or cascading that message out there and being proactive about it is what we should do with our mentees, I think.
Yeah.
One of the things that Dr. Poyner brought up when we were talking is that we can just look at certain things as aging. So this is just what happens when I age. I lose strength, or I'm sleeping. And one of the things she had said, sometimes, yes, those things are aging, but sometimes it's not an aging problem, it's an estrogen problem, right? And so if you can look at your levels, then, you know, you can help with those symptoms. Did I say that right?
Mm-hmm.
Yeah. So
I guess on the other side, since I still have the mic, are there?
Take it back.
Take it back from you guys. But as we think about, I work in the world of advocacy, and this healthcare is a big issue. The ACA tax credits are coming up and everything. What should we be advocating for that's covered? And it may be a deeper conversation, but how should we be using the power of our voice, and what do we need to get for ourselves, as well as, again, younger folks that we didn't think about or didn't know to ask for in the past?
I think in terms of advocacy, a couple of things to get paid for. One is to get estrogen paid for if you're going to take it, right? Because right now some insurance companies are very difficult. There's lots of hoops to get through it, right? I think Ireland was doing estrogen free for everybody. UK certainly has a better system for estrogen, getting it to women without a high price tag. The second is coverage for, menopausal issues, with insurance companies. Oh, you saw the doctor twice this year, we're not going to cover that exam, or you get one annual exam. Well, you may need some more frequent visits if you're going through some menopausal transitions or using some hormone support, or if not, if you're using lifestyle support. That's the second thing. The third thing is to get, I think, we need to get tech involved, and this also eliminates healthcare disparities. There's some great data coming out of the genetics world that if we can get resources to women that don't involve, trips to the doctor and this type of thing, so we need to get tech involved to get answers for women and to get education to women. And there's been a number of studies, like I said, in the genetics world that have shown the efficacy of this. But I think getting coverage for women and menopause. And the other issue is coverage in the workplace, right? So menopause in the workplace is huge. It's something like 69% of women have had issues with menopause in the workplace in a study, again, from Ireland, an Irish nurses study that showed that many women, like 30%, didn't seek promotion because they felt too timid to do it, or they felt they were having menopausal symptoms and they didn't feel like themselves, and so they didn't seek promotion. So we also need to advocate for coverage and policy of menopause in the workplace also, and that comes from education.
Hi, Suzanne. Unfortunately, the second one in the front, I was one of those reluctant people to take a picture, but I owe Robert and the team at Brace Life a tremendous amount. I was also a super early adopter of HRT. I think I had 1 month of hot flashes, called my doctor, and got the phone call, congratulations, you're in menopause. So it's been a complete game changer. But my question is, once you're on it, is what they give you in the beginning what you're always on, or does that even fluctuate? How much do you need to, I get my blood checked every couple of months, but how much do you need to keep on top of it? And then also sort of there's all these rumors about testosterone and libido, and where does all of that come into play once you've gotten the hot flashes, memory loss, brain fog, fatigue, all under control? Then it's like other stuff starts to pop up because everything is, seems to be working okay.
So in terms of levels, kind of in the ovaries don't just turn off, right? So they kind of, unless you've gone through surgical menopause, they don't just turn off. So the ovaries kind of gently, they taper down basically. So during those first years when you're using hormone support, generally we have to dose escalate a little bit, and then things stabilize. Between the ages of 60, 65, hormone levels really kind of flatten out and stabilize. And that's when you're kind of on a stable dose. And the question now is how long can we leave women on hormone support? And in the past was, you're going to come off that at 59. Well, no, we actually will let people stay on it much longer now. But you probably don't want the estradiol level of a 40-year-old when you're 65 or 70, right? And again, there's no data to support, do you change dosing? But you should have some intermittent levels checked. I don't want to, in my personal preference is not to see a 70-year-old woman with an estradiol level of 100, So, but definitely sometimes we come down a little bit. And then in terms of testosterone, I mean, it's kind of the Wild West in testosterone right now, right? We've used it a lot in our practice for, 20 years actually. But there are benefits from it. There are definitely proven libido benefits from it. There are definitely brain health benefits. Through the mood actually improves with testosterone use. You just have to make sure that you're with somebody who has experience in the use of testosterone, and make sure that you're getting what we call physiologic levels, are not very, very high levels. Some people will put pellets in, but these levels go up to a testosterone level of 700. Kind of a normal level for a younger woman with testosterone is between 25 and 30. So probably a level of 700 is not that great, So you just have to do it kind of smartly in a wise fashion.
Hi, I just asked one question, then I'll give it to you. I think you may have answered it, but as someone who's been in perimenopause the past year, as I'm sitting here, I'm like, I can't believe I haven't really done anything about this, and I've just been dealing with, today I've been shaking hands because it's been a hot flash day. That's been insane. But the item that really concerns me is brain health. and I see the difference in the past 2 years. And now I'm even nervous sometimes to make client presentations or to do meetings, which are an integral part of my job, because a question may come that I know deep down I know the answer to, but I'm like trying so hard to get it in front of me. So as I'm listening to you talk about HRT, I realize, okay, this is something I should probably look into. But is it, and I haven't looked at all, so I know nothing if this question sounds ignorant, is it that there are multiple types, like, I mentioned brain health, but I have several other symptoms that I've seen. Is this just one thing that will be given to deal with all of that? I know you said it's art, not science, so it might be trial and error, but hopefully that makes sense.
Totally. So it's a mixed bag of symptoms, right? And we don't really understand why some women have some symptoms, some women have other symptoms, or a combination of symptoms, or no symptoms at all, right? So we generally try to treat to the symptom that you're having, actually, and looking at your levels and seeing the outcome. So some people with kind of brain fog issues will actually respond a little better to progesterone. Some will respond a little bit better to estrogen. Sometimes that's a little bit of trial and error because there's no algorithm that's been developed for this, actually. And the responses are so varied. It's the time of the most highly personalized medicine, but you're not alone, right, in this issue of memory. I just remember one of my good friends, who's my patient, actually came to me. She goes, I spent so long to get the head of the table in the boardroom, and now I can't remember my name. And she's like terrified to walk into a boardroom. So I speak to your physician, speak to your healthcare provider. There's a list of resources that I can give out, whatever. But yeah, I would speak to somebody about it because it is totally correctable, actually.
Thank you. I have a question. So is there like a minimum level of estrogen that you should be on? Because I can't even tell you how many GYNs, and I work for a hospital. I can't tell you how many different ones I went to. One was like, no, I'm not giving it to you. Another one, she gave it to me, she gave me the pill. And like, that's how and until I talked to Francis, she was like, no, you need this bioidentical one. And I was like, man, I had a whole conversation with this lady and she gave me a pill. So I found another one and she kind of like, rushed through it, but she gave me my gel. And my gel is like 0.5 milligrams. Is that like an intro level? Should I be higher? Should I be lower?
So in terms of like where you start, right? Transdermal or a gel or a patch is always safer. But we as healthcare providers should know that, right? And in Australia, they have like this great algorithm, right? It's just like every family practitioner, they look at a flow chart, like what are your symptoms? Okay, this is what I prescribe. It's very simple and straightforward, right? In terms of dosing, there's great variation in the absorption of transdermal estrogens, which are safer. So this is why many people will check levels. Some people are like, you don't need those levels. Actually, you do, right? Because you want to see that you're absorbing it, right? And then you also want to make sure that you're getting levels, I think, and this is just from interpretation of the data, you want to get a decent level, right? You don't want a level of 20, right? Because you're probably not getting great cardiac or brain health protection at that level. So you want a good level, right? But a lot of doctors and a lot of providers say, you don't need to check levels, just dose to your symptoms. But then we don't know that you're getting all the benefits from it. So, and we don't have that data that you get benefits at these lower levels yet.
Can you just talk about natural versus synthetic? Is that the other thing that I hear about, which kind of sort of what you're looking?
Yeah.
Like where does the data?
So synthetic progestins or Provera, and we still have some preparations that are out there that synthetic. Those are the ones that cause breast cancer. So, and that's like the same progestin as in a birth control pill. That equals breast cancer. Naturally, you want an oral progesterone that's usually given as a pill, sometimes transdermally or transvaginally, but usually as a pill. And you want either a gel or a patch is a great starting. That's just a really generic, safe starting point where we have all the safe data.
A question in the back?
Oh, yeah, I wanted to ask a question. I'm Christine, thank you for
Coming to answer questions. I wanted to ask about surgically induced menopause. So I'm 59 now, but when I was 48, I had stage 3 ovarian cancer. So I did have surgically induced menopause, and it was but very dramatic. And I've asked a few doctors since then about estrogen, and they have definitely said like a firm no, but the menopause symptoms have continued, and it's challenging. So I'm curious to know what you think about that.
So with ovarian cancer, we will speak to some women about hormone support depending on the level of symptomatology and how bad the symptoms are. And that's always a risk benefit kind of ratio and where you are in your treatment and that type of thing. In the past, we did put some women who had a history of ovarian cancer on estrogen. That's kind of tapered off a little, that we don't do it so much anymore. But if your symptoms are significant and depending on your type of cancer, not all ovarian cancers are the same. You can also look at, are there estrogen receptors in the cancer on the primary tumor? So there's a whole, so not a hard stop no. Most people will say no, but not a hard stop no. Looking at risk and benefits is, but all this is again where lifestyle comes in, which is so important actually, and in terms of exercise and strength training and anti-inflammatory nutrition.
Did we have any more questions? Yeah. We have two. I see two more. Okay.
Just for the advocacy and everything else, it's, yes, eating better, working out, doing all those things, but life's hard, it's stressful, it can undo all that wonderful work. But if you do say those things to your gynecologist and you seem fairly healthy, they'll send you on your way. Like, you're doing good, you're fine. You were saying that when you put people on estrogen or testosterone, or they check the amounts. Can we say, when you're just doing your annual blood work, yes, test my vitamin D, test my thyroid, test my estrogen, test my testosterone. Can we ask for these things, and they're normal to ask for? And is there a number that can say, you need to be worried about this? Everything else looks good, but that number is wrong. Because if your cholesterol is wrong, they'd call you back in. If your thyroid levels are wrong, they'd call you back in. And this seems so gray. I'm like shocked by that.
So with hormone levels and FSH levels, estradiol levels, if you're still cycling, right, those are going to largely be normal. You can check them early on. Once you order a test, you have to what I call own that test and have to understand how to interpret that test. So a lot of people won't understand how to look within a normal range and listen to a narrative. So we try to, a lot of times in medicine now, make everything binary, right? And algorithmic, right? And I spoke a little bit about an algorithm. They can be great, but sometimes in perimenopausal time, they're not great, right? Because you have to combine laboratory data with the patient narrative, right? You can certainly ask for hormone levels when you're perimenopausal or premenopausal. You may get a little bit of pushback. You don't see FSH or hormone levels change until the late perimenopausal transition. That's when we start to see the levels change. You can always ask for a testosterone level, actually, especially if you're having some symptoms, right? The question is what do you do with a low testosterone? If you're asymptomatic, probably not do anything with it. But definitely, I think it's a conversation. This is where a dialogue with your healthcare provider is really important. And if they're not willing to have that dialogue, that's a problem. They should at least have a reason, that they will or will not do something for you. And then you have to be, you just have to be able to interpret it. A lot of times people don't like to do things if they can't interpret them. I've been asked about the Dutch test, which I love. So Dutch test is an integrative test. Kind of my view on this has always been we can pull from the allopathic world or the Western medicine world or the integrative world. And I think women's health is right in the middle of that. I think we can pull from great integrative health and great allopathic health. And Dutch test is a dried urine test that we can look at your hormones over a cycle. I love it because before you see your FSH go up or your estradiol level go down, you can see subtle changes in your cycle over a period of time. And that's done with this Dutch stands for dried urine testing hormones. Cortisol is in there somewhere. But I love the Dutch test. And kind of one of the things that I'm looking at right now is can we correlate Dutch test with biologic clocks and how can we look at subtle hormone changes and what it's doing to our biologic clocks, actually. So love Dutch testing.
Two more questions.
The HRT, right, the hormone therapy, is there not hormone enhancements that's also in birth control that people experience early on in their life? I have this theory in my head because I'm one of the last Mohicans amongst my friends. My sister's 67 years old and she keeps screaming on me like, you're still seeing your cycle. What's happening? A lot of my friends have finished and had their first 12 months free, so they're definitely in menopause. Nobody's really going crazy up and down. I'm the last. I'm 50 now. I'll be 51 in March. I have this theory in my head that everyone who touched birth control in their 20s, 30s, teens, 20s, 30s, reached the end of the cycle before people like me that didn't do birth control. Is there some truth to that? Because you got it all in the beginning in your 20s, and then there's this kind of post-hormone world.
So there may be a subtle shift of menopause, age of menopause with birth control pill use, but it shifted a little bit later, actually, meaning that you go through menopause a little bit later if you've used birth control pills. But super subtle. I mean, I mean, it's just a suggestion of in the data. In the past, we used birth control. We thought that birth control pills were somewhat protective, actually, so that when we had people who were getting treated with chemotherapy, we put them on a birth control pill to try to protect the ovaries. That data didn't really pan out, but there may be some slight level of protection, but probably not, actually, in terms of cycling. Yeah. So the average age of menopause in this country is between 48 and 50, depending on race, right? So depending on race, right? So Black individuals, actually average age of menopause is 48. Asian individuals, average age of menopause is like 53, a little bit older. Caucasian, there's white, it is like 50, 51, actually. So there's some, and this is an area that we have to really look at too, because there's not a lot of research related to race and ethnicity related to midlife women's health, actually. So a little bit different.
That was my question. Are there clinical trials to sign up for? Can you dole out these Dutch tests so I can take a couple of them?
So look at the website 6 months from now, actually. I love Dutch. I mean, Dutch testing, if you really look, some of the allopaths like, I don't believe in that Dutch testing. And I'm like, you should, because it's very well validated, actually. And you can actually listen to somebody's story and narrative and say, I think they're low on progesterone. And the Dutch is low on progesterone. It gives us a data point of kind of consolidating that narrative. So, but 6 months, there should be a clinical trial up and going.
So along the same lines that you were discussing, I'll be 54 in January, and in consultation with my doctor, I continue to take pills so I don't have a cycle, and I'm wondering if that has any effect on why I am still having a cycle, and I'm almost 54.
So you take it continuously so that you don't have a withdrawal bleed.
Correct.
Correct, yeah. So if you want to kind of find out where you are in that transition, right, you have to come off the pill for at least a week, and then you can get some key indicator where you are. But right now you're everything's kind of covered up because you're using this ethanyl estradiol, which your body sees as estradiol. It's synthetic. But generally we talk about, we speak about taking people off of a pill between 50 and 51 because you have to look at blood pressure. Stroke risk goes up actually as we age, so higher risk of stroke with the birth control pill than a hormone support. So generally kind of what I recommend is around the age of 50, like just, coming off the pill for a week, checking your hormone levels after a week, and kind of seeing where you are in that transition, actually.
Wow. Wow. Thank you guys so much for being here, for participating in this conversation, for having so many great questions. Huge thank you to Robert for hosting this. Thank you so much. Huge thank you to Dr. Elizabeth Poyner for coming here and sharing all of this knowledge with us. I hope you are walking out of this door today knowing more than you did before you walked in, and you feel empowered.
empowered about your health, about your bodies, and your overall wellness. Thank you.
All right, guys. Yes, please stay in touch. We're going to be disseminating more information. So hang out for a little bit. We're going to take a toast before everybody leaves. And thank you for coming.